Welcome back, everybody. Welcome to this session on modeling antibody responses. My name is Thomas Dorlo. I'm associate professor at Uppsala University. Today we have two talks on modeling antibody responses just before lunch. And the first speaker is Iñaki Troconis. He's a professor of biopharmaceutics and pharmacokinetics at the School of Pharmacy at the University of Navarra in Pamplona, here in Spain. And he leads a research group in pharmacometrics and systems pharmacology, covering a wide spectrum of aspects related to the application of mechanistic modeling in a diverse range of therapeutic areas, such as immuno-oncology, but also rare and autoimmune diseases. He will now present also on behalf of Xenia Paraguayen, who's currently on maternity leave, covering the work on development of mechanistic platforms to optimize development of oncolytic viruses, with the title Modeling the Dynamics of Anti-Drug Antibodies in Cancer Patients Treated with Oncolytic Virus in Monotherapy or in combination with immune checkpoint inhibitors. Iñaki, the floor is yours.
Thank you very much, Thomas, for the kind introduction, and thank you very much the scientific committee for giving us this opportunity. So this work represents a scientific collaboration between the University of Navarra and Merck San Anton in the US. So here are the topics that will be covered during my presentation, and let's jump to the potential relationships between immunotherapies and anti-drug antibodies. So here in this plot, we see how the number of FDA-approved immunotherapies has grown over the last 2 decades. At the top, we have the immune checkpoint inhibitors, and at the bottom, we have the CAR T cells. So I think there's enough evidence to think that those therapies can trigger an immune response leading to the formation of anti-drug antibodies, which might compromise treatment efficacy. What do we know about the relationship between immune checkpoint inhibitors and ADAS development? So that development is fairly low, and the impact on, for example, drug clearance is considered limited. The clinical relevance and impact on drug efficacy is still uncertain. For example, in the plot that we have in front of us, we plot the number of articles reporting ADAS development. And we can see that for the vast majority, there is an unknown effect on the impact on the clinical efficacy and clinical response. Regarding modeling efforts, most of them have focused on including the impact of ADAS as a covariate. For example, presence of ADAS, absence on drug clearance on other model parameters. So given that, the objective of this work is to develop a semi-mechanistic pharmacodynamic model characterizing the dynamics of the anti-drug antibodies in cancer patients and for, I think, novel therapeutics. For example, one based on monotherapy with the oncolytic virus V937, or in combination with the immune checkpoint inhibitor pembrolizumab. We were dealing with data after intratumoral administration of the oncolytic virus or intravascular administration of the oncolytic virus. And an extended objective was the assessment of the impact of this ADAS development on the viral kinetics and tumor response. So what about the data? We have, as I said, monotherapy with the oncolytic virus, combination with pembro. We have a wide range of dose levels for the oncolytic virus and multiple cycles. And for example, in that busy table, we need to focus our attention to the fact that in this analysis, we merge together data from different cancer types. For example, We merged data from melanoma, non-small lung cancer, different types of prostate cancer and bladder cancer. The number of individuals is roughly 200. Regarding dosing schemes, we have at the top of the slide what dosing scheme for one of the 4 clinical trials involved in this analysis. The virus was given at day 1, 3, 5, and 8 of the first cycle, and Pembro was given at day 8 of the first cycle, and then later on as a 200 milligram during 30 minutes intravenous infusion. We continue with data presentation, but in the next slide, focus our attention into the longitudinal profiles. We have in the upper panels the PCR normalized by the virus dose over time for monotherapy and combination. And we split with using different colors the different routes of administration, intratumoral and intravenous. The information that is provided in the lower panel is similar, but in this case corresponding to the anti-drug antibodies. We have samples up to 600 days after the start of the treatment. In the table, we see that the data come from roughly 200 patients. We have 3,500 data points to develop the model for the viral kinetics, and 2,000 to develop the model for the ADAS dynamics. And roughly between 30 and 40% of the data were reported as below the limit of detection. In the next slide, the information provided is very similar, but in this case, we see the data is stratified, but the route of administration. If we look to the panels in the bottom, and for the case of the intratumoral administration, we can see at least visually that the dynamics of the ADAS is different between monotherapy and combination. So what about the modeling strategy? It was quite intuitive from a point of view. We use a sequential and integrative approach. In the first step, we focus our attention in developing the pharmacokinetic model for the virus. And we use, just for model development, the data that were obtained during the very beginning of the treatment, just up to the 3rd dose, because we are assuming that we're clean data, because we are assuming no other development up to that time. And then we evaluate model performance with the rest of the data using simulation. This step also, we tested the covariate ADA as a binary covariate on drug clearance. In the second step, we try to develop the model for the ADAs. We use the population parameter estimates that we obtain in the first step, and we perform as well on covariate analysis in the second step. Then we try to build a simultaneous analysis for the viral kinetics and ADAS development. Lastly, in the fourth step, we try to come up with a relationship between ADAS dynamics and tumor response. We analyze the data using the population approach with NOMAN74, and for the simulations, we use the Simulix tool. So regarding the pharmacokinetic model for the oncolytic virus, we have the schematic representation of the final model. It's a 3-compartment model. And in this case, one of the compartments outside the central compartment correspond to the tumor. In fact, we could estimate kind of a parameter representing the local bioavailability, the percentage of the dose that was given of the oncolytic virus that reaches the interstitial compartment. That value was roughly 20%. The rest, the 80%, went directly to the vascular compartment. We can see that the apparent volumes of distribution of the 2 compartments outside the central compartment are quite high, suggesting that the virus can distribute in tissues and organs beyond the tumor. That's something that we could prove experimentally with data from preclinical analysis, where we see that in some occasions, the virus can accumulate in healthy tumors and tissues. And the panels that we see in the plot indicate that the model performs well for both types of responses, the sensor observations at the bottom, and for the PCR values in the upper panels for both intratumoral and intravenous administration. When we use these model parameters to simulate the rest of the data, we could see that the model performance was adequate. So at that time, we have finalized the pharmacokinetics of the oncolytic virus using the model and model parameters that we have in front of us. What about the anti-drug antibody model? This is the schematic representation. This part has been already discussed. And we use a turnover type model to be able to generate and to predict the developing and the degradation of the others using first order rate constant of synthesis and degradation. We can see that the model is capable to describe quite well both types of response again, the others and the percentage of data below the limit of detection. We can see in the table that the magnitude of the inter-individual variability for the 3 parameters of the model associated with variability is quite high. We try hard to incorporate covariates in order to reduce and to explain that great variability that we found in our base model. It's true that we found some significant decreases in the minimum value objective function, but the model becomes quite unstable, highly dependent on the modeling strategy. The data description was not really improved, and so on. And we can see here that the base model and the covariate model performs very similarly. So that's why we use our base model as the selected model. It's true that data, we had some indications that, for example, the others development was different, for example, if we compare the intratumoral administration versus the intravenous administration. But I think the data did not support really an estimation for that effect. So what are the conclusions up to now? So the treatment with the oncolytic virus indeed triggers an anti-drug antibody response that in this case could be modeled semi-mechanistically with, I think, not really complicated models. And we didn't find an impact of these ADAs on these viral pharmacokinetics in any of the scenarios, intratumoral versus intravenous, and monotherapy versus combinations with the immune checkpoint inhibitor. But what about tumor response? Recently, we developed a minimal PBPK model for this oncovirus distribution. It's a kind of complicated model. We expand that PBPK model to introduce drug response, mainly driven by the CD8 activation. So we thought maybe we can use this model and the one that we have developed and described now, and try to merge both of them to explore the effect of the ADAS effect on tumor response. So we expand a little bit the previous minimal PBPK model, and we include some extra component in our model just to allow these ADAs to distribute into the tumor compartment. And then we start to explore different aspects of the oncolytic of this ADAS effect. For example, we started to ask ourselves, what if these ADAs reduce viral infectivity? So we saw that when we have a virus with high infectivity and very, very low replication. There is no effect on drug response. I'm talking about monotherapy and intratumoral response. After intravenous administration, the tumor response was really marginal. However, if we decrease infectivity, we go from high infectivity to medium infectivity to low infectivity, and we go from no replication, low replication, high replication, we start to see an effect of the ADAS formation of the response. In fact, this neutralization can shift from a responder to a stable disease and to a non-responder. And that's basically what we think is happening in our data, because we know from the modeling effort that we perform from in vitro data and in vivo preclinical data that this virus in particular is associated with very high infectivity. And in our clinical model, we could not estimate a parameter of replication. It was fixed to 0. So in our case, we have this scenario, high infectivity and no replication, this one. So we are not expecting, in this particular case, an effect of the ADAS development on the tumor response. That's precisely what our data is telling us. For example, here we are splitting our data between intratumoral monotherapy, intratumoral combination, intravenous administration, and intravenous combination. And we have, for each panel, with different colors, the complete response, red, partial response, stable disease, and disease progression. And we cannot distinguish between the different degrees of the response based on the ADAS development, suggesting that, in fact, this is the expected scenario based on our computing simulation, assuming high infectivity and no replication. So those are the conclusions. A population model for the oncovirus plasma level and 3-year ADA development has been successfully developed. And jumping to the second big bullet point, previous mechanistic knowledge has been leveraged to provide a better understanding of the ADA impact on tumor response. And this quantitative approach, we think, can be adopted in other clinical scenarios. I'm going a little bit late, but nevertheless, I want to put a photo of the group. And this is the small one that recently came 10 days ago. Thank you very much for your attention.
Thank you, Inaki. We have time for 1 or 2 questions. If you have a question, please proceed to the microphone and introduce yourself with name and affiliation, please.
Can you hear me?
Yes.
Joey Leung from GSK. So I'm wondering your conclusion on the replication rate versus infectivity. Is that applicable to like natural viral infections?
I think it's a good point, and we didn't think about that, but certainly we need to explore that possibility. I mean, we were driving our conclusion since we, as I said, during our modeling exercise, both at the preclinical level and the clinical level, we could not estimate the replication. And I remember that it was not a question of parameter identifiability. Since we fixed that parameter to 0, and the data were described well. So.
Thank you.
We have one more question in the front.
René Bruno, Genentech. Nice presentation, Iñaki. Nice model. You said that you looked at the covariates effect on ADA dynamics, right? And you couldn't find anything stable, but did you try to figure out what were if there were any patient characteristics that were associated with ADA development versus the patients who are not developing any ADAs?
Well, if I have understood correctly your question, we tested for significance a set of covariates. And the only ones that saw something was the treatment, combination versus monotherapy, and intravenous and the route of administration. But of course, you do not remember the data that I presented in one small table in my presentation. But we have a very imbalance regarding data points, for example, after intravenous administration. We were dealing with 3,500 observations, for example, and for that particular group of patients, we have roughly 300. So I think maybe it was a question of imbalance. I don't know if I have answered your question, René.
Okay, yeah. Thank you.
Thank you, Iñaki. So the next speaker is Quentin Clairon. He's a researcher at INRIA Bordeaux Sud-Ouest and Bordeaux University and works within the SISTM team led by Professor Thibault. Quentin mainly works on two interrelated topics, mechanistic modeling of the immune response induced by vaccination and also the development of statistical estimation methods of dynamical models used for clinical trial data analysis. And he will now present his work quantifying the vaccine-induced antibody response against SARS-CoV-2 with the title Modeling the Kinetics of the Neutralizing Antibody Response Against SARS-CoV-2 Variants After Several Administrations of BNT162b2 Vaccine. The floor is yours, Quentin.
Okay, thank you for the presentation. So yeah, I will present a joint work about modeling of the evolution of antibody activity induced by sequential vaccine strategy based on mRNA vaccines. So the point here is to predict and quantify as precisely as possible the protection coming from antibody activity induced by vaccination, and more particularly, the variation of this protection coming from one injection to another and the differences between variants. So why this interest? Because it has been observed that after a dramatic effect at the beginning of the vaccination campaign in terms of reduction of severe disease or transmission and disease acquisition, there was a subsequent reduction of this initial vaccine efficacy, mainly due to two phenomena. The increasing elapsed time since last injection among vaccinated subjects, and maybe more importantly, the emergence of variant of concern less sensitive to the vaccine-induced protection, which initially targets the historical strains of the virus. And indeed, observational study suggests that there is dramatic variation in terms of vaccine efficacy between the different variants, in terms of protection against symptomatic or severe form of the disease, and this protection is strongly dependent to the number of injections, for which each additional injection can dramatically enhance the existing protection. One can think, for example, of the dramatic effect of the third injection of mRNA vaccine against Omicron. So what we want to do here is to precisely characterize, more precisely than using observational study, the protection evolution by looking at the evolution of antibody activity at the within-host level. And for this, classically, we can look at the evolution of antibody concentration evolution, and we hope that the higher the concentration of antibodies, the higher the protection. And also it allows us, by looking at evolution with time, to quantify the waning immunity phenomenon, so the decrease of protection due to decrease of antibody concentration over time. And such measurements are available in the cohort we will focus on during this presentation, in which 26 subjects who received up to 3 injections of Pfizer vaccine has been followed. And you can see here, so an increase after each injection. The square here represents the mean value among the cohorts. An increase so from one injection to another in terms of concentration, followed by a decrease with respect to time. The problem is you cannot tell the difference in terms of protection between variants from this data only. You need to look also at the neutralizing activity of the antibody against the virus. That is the ability of the antibody to bind to the viruses and prevent them to infect target cells. And one interest of this presented cohort is the fact that we have measurement of this neutralizing activity for the same patient who have access to antibody concentration measurements. The measures are given in terms of ED50, so basically it's a dilution factor which quantifies the loss of neutralization induced by a dilution of a given patient sera. But very briefly, the higher the ED50 value is, the higher the neutralizing activity is. And also, it's a variant-specific measure. So we have here a measure for the historical strain of the virus, but also the variant alpha, beta, delta, and different substrain of Omicron, BI1, BI2, and BI5. And similarly, as antibody concentration evolution, you can see that there is an increase from one injection to another, but still now with huge difference in terms of neutralizing activity between the variants. But still, it's complicated from raw data only to precisely characterize the evolution of protection and the evolution from one injection to another. Let alone the fact to, from this data only, to predict the evolution of the antibody activity, especially the neutralizing activity. For this, we need a model. So here we have constructed a model which characterizes the evolution, the joint evolution of antibody concentration and the variant-specific neutralizing activity, as well as the variation from one injection to another. And once this model is constructed and estimated, you can use it to predict the long-term evolution of antibody activity, neutralizing activity especially, way outside the available observation interval. So let us present this model, starting with the parts describing the antibody concentration evolution. It's a differential equation model, which describes basically the interaction between the antigen induced by vaccination, some cells involved in the humoral response, and antibody. So basically, we said that here, the antigen induced by vaccination will trigger the constitution of a memory compartment, roughly memory B cells, which then will differentiate into secreting cell. And then this secreting cell will ensure the production of antibody of concentration denoted AB. Still, we need to keep this model very simple in order to avoid practical identifiability issues due to the fact that in our cases, we do not have access to cells measurements. So we said that the evolution of antigen induced by vaccination could be represented by a piecewise exponential function, and the action here of the memory compartment, represented by Fm, could be represented by a very simple piecewise constant function. Still, this function will change of value after each injection to quantify the change in terms of B cell activity from one injection to another in terms of antibody production. But to this first model describing concentration evolution, we need to add a second part in this model to actually quantify the neutralizing activity of the antibody. Here we use a very simple model, a linear relationship linking the ED50 for all the variants and the antibody concentration, with a coefficient of proportionality given by this function f. Still, this function has to be variant-specific, and also they are time-dependent in order to account for external factor, external to antibody concentration alone, which can play a role on antibody quality for neutralization. And by testing different temporal dependence, I can test the relative importance of different factors acting on this antibody quality. So we have done that by testing, as a start, a very simple model saying there is no external factor, so we took just a constant function. But then we refined the model a bit, saying, okay, there is an intrinsic increase of antibody quality, which gradually appears since the first antigen encounter, but with no effect here of the number of antigen encounter. And at the contrary, we said in the third model, what is the main factor outside antibody concentration, which play a role on antibody quality, is the number of antigen encounters, so the number of antigen injection. And indeed, it was the one which led us with the lowest IKK information criteria value. Moreover, by testing a more complex model, accounting for both the last elapsed time, since antigen encounter and the number of injection, we only marginally improve model adequacy and always at the expense of practical identifiability issues. So in the end, we retain this piecewise constant function for the model quantifying the neutralizing activity, but still we have to account for differences in terms of variance and in terms of injection. So we said that this function took a first value gamma after the first injection, but then we have to update this value to account for the effect of a new injection. So we update this first value by fold changes F2 and F3 to account for potential gain in antibody quality after each injection, but then to account for potential loss for the variants comparing to the historical strain of the virus. We have also added variant-specific fold changes after the first injection and the second one. And finally, to be a bit more precise about the effect of the third injection, we have added variant-specific fold change to precisely quantify the gain in terms of quality for this variant after the third injection. And finally, to account for intersubject variability we observe in raw data, we have added some random effect here on two parameters, on theta, the influx of antibodies, and also gamma, which quantify antibody quality for the historical strand after the first injection. And one interest of the parametrization we choose here is to spread this variability to all the variants after all injection. Then, once a model is specified, we can estimate it via classic maximum likelihood using the monolith implementation of SRM algorithm. So as a start, we can check model adequacy, but here very briefly, as just an example, we give a model fit at subject level for 3 sampled subjects for both antibody concentration and ED50 for the available measurements. And we can see that all the observations fall within this shaded area, so which are the 95 prediction interval, which account for both parametric estimation uncertainty and measurement error. But what we are really interested about is the evolution of antibody activity, in particular neutralizing activity, from one injection to another and differences between variants. And for this, we have to look at estimated parameter. Starting with this parameter, which quantifies the change in B cells activity on antibody production. And we can see that after the first injection, we have a fold change which is significantly higher than 1, and after the third injection, we have a fold change significantly higher than the one after the second injection. So each injection, comparing to the previous one, lead to, according to the model, a more sustained activity of B cell in terms of antibody production, and thus it explains the gain in antibody concentration from one injection to another. But what about the neutralizing quality per constant antibody concentration level? For this, we have to look at these fold changes, which quantify the potential loss comparing to the historical strand. And we retrieved, after the first injection, already observed results in external cohorts. The fact that there is a significant loss of neutralizing activity for beta and delta, and an even more marked one for all the Omicron substrains. But does this sequential injection strategy work? That means, in a way, does it enhance this neutralizing activity? For this, we can look at this parameter, which quantify a potential gain in antibody quality for the historical strand and the variant, so globally. And we can see that they are all significantly higher than 1, so each injection also improves neutralizing quality of antibodies. And more specifically, we can look for the effect of the third injection on the variant to these fold changes. And we can see that, at the exception of delta, they are all significantly higher than 1. So it means that the third injection not only globally improve neutralizing quality, but also leads to some kind of catching up effects for the variants comparing to the historical strain of the virus, but still with huge discrepancy between the variants. And this has consequences on the long-term antibody activity. Now that we have an estimation, we can predict the evolution, the mean evolution of antibody concentration and the ED50 way outside the available observation interval. And let us start about what happened for the antibody concentration. Here, the horizontal line represents the protection threshold, so it was a threshold set by the World Health Organization, which is supposed to be enough to protect against symptomatic form of the disease when you are infected by the historical strains of the virus. And here, we have estimated the required time after the last injection to move below this protection threshold. And we can see that the required time is significantly higher after the third injection comparing to the second one. So it indicates a more sustained antibody activity, but it's not sufficient to look at this to account for the difference in terms of neutralizing activity, long-term neutralizing activity between the variants. For this, we have to look at the ED50, and one can see that indeed from one injection to another, there is an increase in neutralizing activity. Still, the required time after the third injection to move below this threshold is a lower limit of detection, which is specific to our framework, but still it gives us a unique threshold for all variants. We can see that this time is of 17 months for the historical strain of the virus and the variant alpha, but only of 1 year for beta and delta, and not even of 7 months for all the Omicron substrains. So what we have proposed here is a model which allows us to quantify the sequential effect of each injection, and it enlightens the beneficial effects of each injection comparing to the previous one on both antibody concentration level, but also on the neutralizing capacity of antibodies per constant concentration level. But still, these estimations also enlighten the huge differences between the variants. And in particular, our estimations are consistent with a low protection given by the mRNA vaccine against a symptomatic form of the disease when infected by Omicron. To see this more precisely, from the estimated model, we can also estimate the required time for having half of the population with an ED50 below a given threshold value. And here we have computed, after the third injection, sorry. And we have computed this time for an increasing set of threshold and for all the variants. Of course, there is some variability between the variants, but what is very striking here is the fact that for no substrain of Omicron, there is a time after the third injection for which more than half of the population presents an ED50 value higher than 1,000. And this value has been isolated as a correlate of protection against symptomatic form of the disease. Okay, now what we want to do in the future is maybe have a more precise view of the protection still induced by vaccination by finding a value for the ED50, which is a correlate of protection against severe form of the disease. Of course, it does not protect against symptomatic form of Omicron disease, but we know it protects in some way, in some extent, to severe form of the disease. And also to have maybe a model more closer to the immunological state of the population to account now for breakthrough infection in addition to vaccination effects. Okay, I will stop here by thanking all the people involved in this work, and in particular, people coming from Orléans and Pasteur, who set up the experimental design and made the data acquisition. And I cannot stress enough how complicated it is to obtain such data. Thank you for your attention.
Thank you, Quentin. Are there any questions? Please mention your name and affiliation.
Yes.
On top.
Very nice presentation. Dinesh Dialwis. Is this on? Yeah. Hi. Yeah. Very nice presentation. Dinesh Dialwis, Generate Biomedicines. So a couple of things on the model. You alluded to it, but I'm not sure if you, in the population that you built this, did you have immune-compromised patients, the very elderly, cancer patients and others in this model? Because obviously it's kind of reliant on the immune system, and if you don't have it, how does this actually work?
So it's a shame we cannot see the slide, but no, we took a very small cohort because, as I said, the measurements were complicated to make. So it was healthy patients, unaffected at the time of entry into the cohort until the time of third injection. So no, not immunocompromised. We have one, and we have discarded because what can you say at the population level with one subject? So no, and maybe we have to, if we have data for this, maybe we could integrate this into covariates, as always, by maybe playing on either the influx of antibody or the cells production, and maybe more cells production, but still we are in an exploratory phase here.
And just one other follow-up question. You did look at Omicron variants, but did you look at the one that's most relevant, which is XBB 1.5 or BQ 1.1?
No, because we have some data, but not enough to estimate this model here.
Okay, thank you.
One limitation here was practical identifiability issues. I can say practical identifiability issues for all the parts of the model here.
There's one more question on top.
Hi, Nivea Falconer Simulation Plus. Nice presentation. I saw that you mentioned that we have a good quality of antibodies after the increase of the quantity of these antibodies. How do you evaluate that? Did you place this in the model as a covariate afterwards and have any improvement on it?
Do you mean the quality of antibodies,
yes.
The intrinsic quality?
Yes,
it was the parameters, the different fold changes. Oh, sorry, I've just quantify the intrinsic quality. That means you discard the concentration and you just focus on the quality per constant concentration, and you can see an increasing. That was the estimation I showed during the presentation. And you can also quantify the increase specific to a given variant.
All right, thank you.
Question here below.
Mick Luby from Novartis. Did you look at the IgG subtypes over time?
No, here we just have IgG we used as a surrogate value for concentration of antibodies.
So you just looked at total IgG?
Against this RBD domain here.
Okay, because we see that the variants evolve over time, going from 1 towards 4, which has a very different effect on.
Yes, but
immunogenicity?
yeah, we just here focus on one isotype because we have data for it. That's all.
Hi, Gang Zhao from AstraZeneca. So my question is something you didn't cover in the talk, but I just want to comment since you are working on this topic. So I guess the cohort has got a standardized dose. After seeing these data, do you think there's some rooms to play with the dose to optimize the response, or consider their previous infection history? If you measure certain IgG against SARS, other similar viruses, is this a base for you that you can discuss to adjust the dose of the vaccine?
So with this model, we can phenomenologically account for difference due to the difference of dose or previous infection by accounting in the form of covariate on some parameter this previous effect. Still, to account for it mechanically, we need to, for example, for the problem of low doses versus huge dose, bigger doses, sorry, it seems to have an effect on germinal center. So for this, we have to have a model which accounts for maybe more subtle description of memory B cell and memory B cells maturation as well. But we do not do this in this model because we have no cells measurements available. So it will be purely artificial compartment. We cannot do a thing here. So in order to precisely account for it, we need a model which is precise enough and cellular data to correctly estimate this part, I think.
We have time for two more short questions. First below and then on top.
Jean-Louis Steimer, retired from Novartis. I understood a lot, Quentin. Thank you. I'm 5 times vaccinated. How should I wait for the other vaccination?
As soon as I have a correlate of protection against severe form of the disease, I can tell you.
Yeah. Jeff Sachs, not yet retired from MSD. And thank you very much for the very nice presentation and the nice modeling work. Speaking of correlates of protection, you were quoting a single value and using what we in our modeling and simulation for vaccines group call the T word, a threshold. There are a number of publications now that show that protection is a sigmoidal function of neutralizing antibody at its simplest. And have you, 2 questions. One is, have you looked at the impact on efficacy using the continuous description of protection versus neutralizing antibody instead of the very simplistic where you can draw a line, which is useful? And the second question is, have you looked at the neutralizing titers to the variants of interest, including the ones mentioned by my colleague Dinesh, by the newly recommended variant vaccine, monovalent vaccine?
Okay, so for the first part, we are working on it, but we are starting to working on it, so I cannot say a lot about that. But yes, we try to look at the distribution of protection among patients when you use a sigmoid function, not just a single value to have not a yes or no answer, but what is in percentage the level of protection against a severe or not severe form. But we are starting here, so I cannot say a lot. And second point, yes, it will be interesting as long as we have data to estimate the effects, but we do not have such data. Right now.
Great, thank you. And on your work on the first topic, completely self-serving here, there's at least one publication you may find useful, which shows that you can actually predict the efficacy of a vaccine using these continuous functions just with in vitro studies of the neutralizing antibodies that are generated across different variants, even without the clinical data. So you may want to look into that.
Okay, I will.
Thank you.
Thanks.
Thank you once again, Quentin, for this very interesting talk. So this is the end of the morning session. We will now break for lunch. Please come back here in this room 5 minutes prior to 2 o'clock when we will have a keynote lecture on circulating tumor DNA.